So let's finish the kidney cases today. This is a glomerulus we see here, and have a look at the history. This is an obese man who has all these signs of peripheral neuropathy, retinopathy in the eye, abdominal aortic aneurysm probably related to atherosclerosis, and declining renal function with an increasing serum creatinine level. So what can be the systematic disease with all these effects in multiple organs? What's the possible? Diabetes. It's diabetes because you see fasting blood glucose level is too high. Yes. So this is diabetes mellitus. And his peripheral pulses are diminished. Why? Because all blood vessels are affected by diabetes and they are abnormal. So now, as far as the kidney is concerned, all diabetic patients should be looked after for proteinuria. This is the first sign that diabetes has affected the kidney. If there is even a mild proteinuria, it's taken into account in a diabetic patient. So what do we see here? There is an area marked by a sign that it has a problem, taking into account the general morphologic criteria that we see in a glomerulus. What problem is in this area of the glomerulus? There is one on the top and one on the left. What problem is there in these areas? What do you think? You remember what we saw? Are there many cells in the glomerulus? Where are they? Are there few or no cells in an area of the glomerulus? And are the basement membrane thickened? These are the three basic morphologic features we look in a glomerulus. So what of all this applies to this image? What do you think? How could you describe these two areas? How would you describe them? Are there many cells or no cells? What do you think? You see cells there? No, it's only matrix. So what else can it be? If we see a hypocellular area, it could be sclerosis, like here. So we have pus positivity and mainly trichome Mason staining positivity. But it could also be amyloidosis, which is the staining to detect amyloid, Congo red. If you stain here Congo red is negative, so it's not amyloidosis. No polarization under the polarized light. So it's negative for amyloid. So these hypocellular, or better, acellular areas are sclerosis. However, they have a distinct configuration. In this diabetic patient, it's not always the case. And what is this configuration? When we see round structures, these are called nodules. So we have sclerotic nodules in the glomerulus of this diabetic patient, and this is Kimmel-style Wilson nodule. This is nodular glomerulosclerosis. This is a case of an diabetes mellitus of adults, and here is the biochemical abnormality under this morphologic feature, abnormal feature. Oh, here we have a pus stain. What's different in this area of sclerosis, of fibrosis, by comparison to the previous one? There is increased fibrous tissue. However, it is more global. It's not segmental like the previous one. By the way, as we saw the previous image, from what we have already discussed, how could we describe the morphological sclerosis in the previous image with all that we said in the previous lesson? It could be focal segmental glomerulosclerosis, couldn't it? but you never see something and say before you see the history, because that was the history of diabetes. So that goes out of your mind. It's diabetic nephropathy. Something I stressed is that you have to take into account all factors before you make the diagnosis, not just as one morphological abnormality. From this point of view, this previous case could be focal segmental glomerulosclerosis. It isn't. Why? Because it does not have clinical correlation. From a strictly morphological point of view, it can be described as such, but it isn't this disease. And of course, you should have immunofluorescence, which in focal segmental glomerulosclerosis is negative or non-specific. And interestingly enough, I don't know why, in diabetic patients, there is an IgG deposition of a linear type. I cannot explain why, because diabetic nephropathy is not an immune-related disease. However, it's some sort, not so strong. The sign is a bit dim, but it helps. But what helps most is the patient's clinical and laboratory findings, and specifically this fasting glucose level, which is very, very high. So here, don't look at the glomerulus. Don't look at the glomerulus. Are there any other signs of diabetic nephropathy evident in this image apart from the glomerulus? The glomerulus is thickened, not in a nodular way and not in a segmental way. It is global sclerosis in this glomerulus. Okay, whether this is focal or diffuse, we cannot tell. We must look at all the glomeruli in the specimen and decide. So leave the glomerulus. Are there any other signs of diabetic nephropathy as we have discussed in our previous lessons? How does diabetes and hypertension damage the kidney parenchyma? How? And this is evident here, not in the glomerulus, but somewhere else. What do you think? What did we say? That these two diseases cause something where? Tell me.
In the tubules of the...
Not the tubules, in the vessels. In the vessels, in the interstitial arterioles. So what do we see here? You see the arteriole that gives blood to the glomerulus, and how is its wall? It's thickened. This is a sign of, remember how we said that? Hyaline arteriolosclerosis. Okay? Some sort of nephrosclerosis, benign in this context. When we say malignant nephrosclerosis, we mean that there is hypertension and the blood pressure is very, very high, about 30, the systolic one. So this is another sign of the damage that diabetes has caused to this. Let me turn it off because not so cold. Yes. And what else is there? How can you, you see a highlight of diabetes is ketoacidosis. And this is diabetes type 1, that means of young individuals. And how can you, what do you understand taking into account the creatinine clearance value? What is the creatinine clearance? How much creatinine is excreted by the urine? And it's very low. Why? Because the nephrons of this patient do not function properly. So there is some degree of renal insufficiency in these diabetic patients. And if you go at a transplant surgery or when they have diffuse of the blood with filters, hemodialysis, most patients are diabetic patients and hypertensive patients. There is a percentage of patients with pyelonephritis and some with glomerulonephritis, and a minority with polycystic kidneys among the patients who are in in these units of the hospital. So what else can we say here? All right, diffuse glomerulosclerosis and the arterioles, which is the one, this one is the arteriole that brings blood to the glomerulus. This is the efferent, the afferent. So this afferent arteriole, it's a small artery, is thickened, okay? The afferent. I'll have a look here. Now, we have two kidneys, both of which have been, the size of both has been reduced. So they are atrophic. What can cause this end-stage renal disease? Mainly nephrosclerosis, pyelonephritis. It's a bit rare to be bilateral, however, it can be, and nephrosclerosis and glomerulonephritis. Could these atrophic, the atrophy of these kidneys be due to pyelonephritis? No. Why? Because there is no dilation. Remember that chronic pyelonephritis has a dilated pelvis and pyelocalyceal system. In later stages, we have hydronephrosis, and the parenchyma becomes atrophic, but there is a disfiguration, an asymmetrical disfiguration of the kidney's contour. Why? Because it has been dilated. And this asymmetrical configuration is due to scar tissue. This is not the case here. Here, both kidneys are homogeneously shrinked. So this is possible due to chronic glomerulonephritis, because if it were due to nephrosclerosis, how would their surface be? What happens to the surface of the kidneys that are reduced in size due to nephrosclerosis? What is nephrosclerosis? Is hyaline arteriolosclerosis related most often to diabetes and hypertension. In such cases, how is the surface of the kidneys, of the atrophic kidneys? How is it? Yes? Yes, there are some small granules. What are these granules? There are microinfarcts of the small vessels which have the hyaline sclerosis, and they cause all these small infarcts and give the surface of both kidneys a granularity. So in this case, most probably is chronic renal failure due to chronic glomerulonephritis. Not the most common case of renal failure. And what is the kidney that we see down, the pelvis? That's the transplant, okay? And if there is no reason, you leave the kidneys in their place and put the plasmas down the pelvis. And however, if the atrophic native kidneys themselves cause a problem, you take them away. And what problem could they cause? Hypertension. Because if they become atrophic, the juxtaglomerulus apparatus is triggered, and we have renin production. And what else can it be? If there is chronic pyelonephritis and hydronephrosis, we have constant infections. But in such case, that was the damage, the severe damage that caused end-stage disease was due to glomerulonephritis, so there was no point in resecting the atrophic kidneys. They did not cause hypertension to the patient, to this patient, so they just put the transplant in the pelvis. And what else do we see? Hyaline obliteration of the glomeruli. Yeah, in such cases, since all parts of the nephron relate to each other, it's very difficult from a histological point of view to define where the damage started. So you need the history. If you have end-stage disease, tubules are atrophic, scarring is in glomeruli and interstitial tissue, and you cannot say where it starts from, but you take into account the patient's history to define that. Yes. All right. Now let's have a look at the value. Yes, please.
There it said about pyelonephritis, and you said it cannot be chronic pyelonephritis. In the answer, it said that
in that case, it's not possible. It's not probable. Why? Because there is no dilation. The kidneys have become atrophic, but they are not dilated and asymmetrically disfigured. Okay? But there is a cause of end-stage disease, not so frequent, because to have bilateral hydronephrosis, that's something rare, because either you have a neglected prostate gland hyperplasia and causes reflux and dilation bilaterally, or you have a tumor someplace in the retroperitoneum and it presses both ureters, so both kidneys are dilated, their pelvis system. These are rare cases of pyelonephritis. So have a look at the values here in the blood and tell me how you can evaluate these findings. So serum creatinine too high. What does this mean? If we have this value of creatinine?
No clearance.
Yes, this is renal failure, okay? If it's something that does not give urine at all, this is acute renal failure. The main cause of which, remember what is the main cause of acute renal failure, where you have very, very severe oliguria or anuria? Acute tubular damage. You said, in patients who have multiple traumas, etc. So here, so we have renal failure probably on a chronic base. Why on a chronic base? Because we see both kidneys in the CT that have become atrophic. Their size have diminished. Next, the clearance, the creatinine clearance level is too low because the kidneys do not function and so they do not excrete creatinine in the urine. How is the hemoglobin level, the diminished hemoglobin level in the patient's serum justified? How can you explain that he has a reduced hemoglobin level? Probably an induced hematocrit value as well. Why? Why does this patient with renal failure, renal insufficiency, has a reduced hemoglobin level? Think from your physiology and you'll tell me. It's not, yes, please.
Because of increased production of erythropoietin.
Yes, there is excellent. This reduced production of erythropoietin. Why? Because the kidneys have become atrophic. So where is this secreted from and produced? I think there is some fibroblasts in the interstitial tissue. I think so. I'm not sure. But anyway, in patients with chronic renal insufficiency, chronic renal failure, there is decreased hemoglobin. And you auscultate the heart. I think we said that in the circulatory system, you listen something like the shoes I'm going to buy today because the prices on Black Friday were too high for me. This is my week where I go shopping. No, it was too high. But when you take shoes and you do that, take Google who is playing with his mobile right now. Please check in Google friction rub, please. I want to hear what the two layers of the pericardium, which sound they produce in this patient with chronic renal failure. So I want to listen to the friction rub. Found it?
The plural?
No, pericardium, pericarditis, friction rub. Yes, you found it?
No.
Yes, the friction rub.
Why are the kidneys atrophic?
Why are they atrophic? If they are symmetrically atrophic, this might be either to hyaline arteriolosclerosis or chronic glomerulonephritis. If they are of atrophic parenchyma but somehow disfigured due to dilation, it's chronic pyelonephritis. So you found the friction rub. Let me listen to the friction rub. Ah, yes. Oh, very. See, everything is here. So when you have theoretic lessons next semester, how to listen to the heart and all this nonsense they tell you, and in slides, say no. Lazarus told us to check them up in YouTube. Oh, here it is. No, the baby is not for me. I'm 60 now. It's not my time to have another baby. No, no. Why? No, because I took care of the baby, not my profession only. No, because I was a pathologist and I could do that. Take that into account. Take that into account. It's the quality of life, an important factor. So what we were saying now. What does this, why is this pericarditis? Because all the toxic substances in the blood which cannot be excreted in the urine circulate in the blood, and they go to the serosal layers of the pericardium, and there is an inflammation in the pericardiac sac, as we've discussed. All inflammatory exudates which form in areas of serosal membranes, that means membranes covered by mesothelium, all these inflammatory exudates, either if they are in the pleura or in the pericardium or in the peritoneum, these inflammatory exudates are rich in which substance? Fibrin. So if inflammation persists, fibrin strands organize into strictures. So the whole heart is entrapped in the two layers. So when it works, when it functions, the two layers rub with each other, and you have what you heard here before the baby came, because then not the baby, that was a commercial, not then. What was before is what you hear. Okay, now, yes, please.
You said the two causes of symmetric atrophy. It's a chronic...
Yes, in this case, I see both kidneys diminished in size, so it could be due either to nephrosclerosis, hyaline arteriosclerosis, due to mainly diabetes or hypertension, and or chronic glomerulonephritis, because they are diminished in size. If you see granularity in the outer surface, it's nephrosclerosis. If you don't see granularities, it's chronic glomerulonephritis. Yes, all right, we discussed this case. Look here. There is a totally different configuration of the right kidney. If you if you compare it to the left kidney. And let's have a look at there is some sort of arrhythmia, and there is an increased calcium with consequent decrease in phosphorus level in the serum. Before we explain this finding, we must think. Think of a patient, no, it's not the case here, it's something having to do with the previous cases. In a patient with chronic renal failure, due to the reasons we have discussed, the calcium level in the serum is reduced. Why? Because when the glomerular infiltration is diminished, phosphorus increases in the blood. So calcium enters the bones. That's why Most chronic renal failure patients have hypocalcemia. So, in such case, which glands are triggered to secrete a hormone and take the calcium from the bones and give it to the circulation? Which glands? Yes. The parathyroids become enlarged, and this is a case of secondary hyperparathyroidism. Why secondary? Because the problem is not in the parathyroids themselves, the problem is in the kidney, and they respond to these problems by becoming hyperplastic. Furthermore, another cause of hypocalcemia is the reduced production of active vitamin D from proximal renal tubules of the insufficient kidney, because these tubules produce a factor, a metabolite, that causes D vitamin to act. And what does vitamin D act? It absorbs the calcium from the gut. So if we do not have enough active vitamin D productions, this is another cause worsening hypocalcemia. So, yes, please.
What is the first reason of hypocalcemia?
The increase of phosphorus, because these two substances, calcium and phosphorus, have an opposite balance. So if phosphorus is increased in the blood, which happens when glomerular filtration rate is reduced, then calcium gets the sign and enters the bones, enters to the bones. So we have hypocalcemia. Another reason for hypocalcemia is the reduced production of active vitamin D.
But the high phosphorus is also caused by low vitamin D, because vitamin D.
By low?
Vitamin D.
Low?
Vitamin D. Because
yes, it's a circuit. Yes, it could be. It could be. However, this is the mechanism that secondary hyperparathyroidism may be triggered.
Doesn't phosphorus complex with calcium?
Don't know that. Have to look it up. Okay? Have to look it up in biochemistry. So, now, in this case, that's quite the opposite, in the case we judge. And if we have a cystic lesion in one of the kidneys, like the right kidney, you see that it is partially cystic. Who can show me on his screen why do I say that this lesion on the right kidney is cystic? What is the cyst like? The cyst is this, the dark one. You see? That because it is empty. So could this be a simple cyst, as we have seen in previous lessons? No. Why? Because there is a variation in the configuration of this partially cystic lesion. So it's most probable that this is not a cyst, but it is a partially cystically degenerated tumor. And in this case, it is a renal cell carcinoma on the right kidney. And taking these findings into account, let's see the profile. Serum calcium here is increased. This is hypercalcemia. How can you explain this in a cancer patient? How can you explain hypercalcemia in a cancer patient? Two things may explain this. What are they? Yes, tell me. Yes, you. Alkinos. Well, it's something like the cancer cells themselves act as neuroendocrine cells. They are not necessarily of neuroendocrine origin. This is not a neuroendocrine tumor, but they secrete something that enters the circulation and acts like a hormone without being the cell neuroendocrine of origin. And this is a paraneoplastic syndrome. So this substance acts like parathormone, so we have increased calcium. Another possible explanation. What has the cancer, where has the cancer spread? Where has the cancer spread? Yes? To the bones. And it caused osteolytic metastasis. That means metastasis where the osteoclasts have been activated, because we have the foreign cells in the bone microenvironment, the metastatic cells, and they activate osteoclasts and absorb the bone, so we have an increase in calcium in the serum. And in this explanation, it is of interest that the active form of vitamin D is involved. And when we have increased concentration of this vitamin and possible prostaglandin E, this osteoclast activation is enhanced. So it can explain the hypercalcemia. And all these sites are possible metastatic sites of renal cell carcinoma. And the key molecular finding is hypoxia-induced factor 1A. This is the key, the target in renal cell carcinogenesis. Here is the tumor. You see that this is a big tumor, and taking into account its location close to the retroperitoneum, it does not give symptoms frequently. It is mainly an incidental finding when you have an imaging procedure for some other reason and you find the tumor. Of course, if it becomes too big, you can have a sense of gravity, a sense of pain, and sometimes there is hematuria, but for a renal cell carcinoma to give hematuria, it has to be so big to invade the pelvis and have some hemorrhage there and give hematuria. This is not so frequent. And sometimes it's also palpable if it reaches large sizes. This is quite a large tumor. And let's see the patient's serum values. Why is the hemoglobin here increased? What do you think? Why is hematocrit and hemoglobin in this patient increased? What does the tumor cells produce as a paraneoplastic syndrome? Erythropoietin. That's right. You see how increased the hematocrit is? So, and the hepatic infarction, how can this be explained? The hepatic infarction, what has happened? Do you remember what I told you that cancer patients are prone to? Cancer patients, it clots, yes, clots are easily formed in their blood. It's one source of hypercoagulum, what's that? Where we have increased, is that hypercoagulative status. Okay, so this might explain a hepatic infarction. And how was this clinically evident? Acute onset abdominal pain. And which veins were occluded to cause the hepatic infarct? What we have discussed in the liver lessons. Which veins? No, after the portal. The hepatic veins leading to the inferior vena cava. These are the ones that cause. Because if we have a thrombus in the portal, there is the hepatic artery that gives blood. So there is no infarct, because liver has two ways of blood supply, the portal vein and the hepatic artery. So the problem has to be after the liver, to block the drainage. And here is another tumor. That was a renal cell carcinoma, an epithelial tumor. This is not an epithelial tumor. It causes pain, and this is a benign tumor, an angiomyolipoma, which can be in the context of a genetical disease named tuberous sclerosis. And you see the three constituents of angiomyolipoma: fat tissue, smooth muscle, and some disfigured vessels, somehow ectatic, somehow with abnormal walls. So this is an angiomyolipoma. It does not give metastasis. It's benign. However, it can be fatal to the patient. What complication are we afraid of in benign tumors? Not metastasis, of course. They are benign. However, we should follow and see if it grows, because it's a benign tumor. It grows. It's benign, but it grows on a local level. What are we afraid of a benign tumor, especially this one, which has an increased number of vessels? You see, angiomyolipoma. Yes, what are we afraid of? Yes, it ruptures. If it ruptures, there is a very blood supply, because it has, the tumor has vessels itself, angiomyolipoma. And of course, the patient may die, may have exsanguination, may die of hemorrhage within the tumor if it breaks.
Professor,
yes?
for something angiomyolipoma, we need all three types.
Most cases. There are some angiomyolipomas which are muscle cell predominant. So they look like leiomyomas. Or there are some angiomyolipomas which are fat tissue predominant, and they look like lipomas. But you should always, before diagnosis these rare tumors of the kidney, have a look at the vessels. If you see vessels that are not of normal shape, they are walls, that's consistent with an angiomyolipoma with some predominant component. And we finish our lesson with bladder pathology, urinary bladder pathology. Let's have a look. If you see this image in the mucosa of the bladder, which is the first diagnosis you give, you think of? This is an erythema. This is a reddish mucosa. What is it? The first, which is the first pathological diagnosis that you give if you are a urologist and you have a cystoscopy and you see this appearance in the bladder. Yes, yes.
Kidney stone.
The?
Kidney stone. Kidney stone.
No, this is not a stone. This is, you open the bladder and this is the mucosa of the bladder. This is not a stone. This is how the mucosa looks. Of course, there could be a stone there in the bladder eroding the mucosa, where it would look like that. But this is a sign of, if you see an erythematous mucosa, what is the first you think of? Yes? We don't know the kidney. For the bladder, it's inflammation. So this is cystitis, and rather acute. So it could be of bacterial etiology, especially if we have a female patient in whom the urethra is short and microbes can easily enter the urinary tract. And you find some neutrophils here, both in the submucosa of the bladder and within the epithelium. What type of epithelium covers the bladder mucosa? Yes, it's urothelium. Urothelium. So let's see the tumors of the urothelium. This is one type of tumor which has an exophytic configuration. When it remains exophytic, it's not dangerous. But in the natural course of the disease, we have invasion through the basement membrane, so cells enter the submucosa. This is T1 stage pathologically, and when they enter, what is beyond the submucosa, which layer is beyond the submucosa? We have mucosa, the urothelium, submucosa, the lamina propria, the connective tissue, and then, which in all, the muscularis propria. This is the extractor muscle. So, if we see malignant cells there, this is T2, pathological T2 stage, and this is an indication of cystectomy. which is a very severe operation, because you know when will the urine go there? How will the urine be excreted? You either form a new cyst in the patient. However, in this case, there is no innervation, so the patient has to go and urine frequently, because he won't know that his bladder is filled if he has a neocyst. And the other is to have an external bag selecting the urine, which is of course a problem. So we must be very careful to define the invasion in the extractor muscle, in the muscularis propria, because this operation will cause some disability in the patient. However, this exophytic tumor, as we can judge macroscopically, was so big that there was no other way to resect it endoscopically. And in this case, if we have a case of panpapillomatosis, of papillary tumors occupying the whole cyst, urinary cyst, you can have surgery as well. But the main indication of surgery is invasion of the muscularis propria. So this is one type of tumors that takes some time to grow exophytically and then invades in the layers of the urinary bladder. It could be low grade, which is frequently non-invasive. Looking the Fricks Rub or the new offers on the phone. What are you looking at? Pay attention. What did you see? Yes? No problem. I'm fine today, no problem. Yes. What were you looking? Yes, tell me.
I'm in the class. I'm trying to
you are entering the class. Don't enter now. We are finishing. Look at the screen. Not now. I sent you the link for tomorrow. You'll have the slides. So, what is this other type? This is high grade by definition. It's not like papillary tumors we previously saw that were either low grade or high grade. This is by definition high grade, and it's flat, not exophytic. This is called in situ carcinoma of the bladder, and this is not a good diagnosis because it is related to an aggressive phenotype, and invasion is imminent. We don't see it yet. However, this is not a good diagnosis. Of course, you can think that since it is not invading, being in situ carcinoma, that's a good sign. Not so well. It's not such a good sign in bladder because this patient has an aggressive type of neoplasia, which most probably will become invasive. And from a molecular point of view, in all invasive urothelial carcinomas, we perform 4 immunohistochemical stains. In which tumors? In high-grade tumors, which are most frequently invasive in the bladder wall. Which are these stains related to the molecular pathogenesis of urothelial cancer? We have GATA3 and psykeratin 20 for luminal type cancers, and cytokeratin 5 and cytokeratin 14 for basal phenotype cancer. So we can give an information to the urologist that the invasive tumor that his patient has either a basal or a luminal phenotype, and he will take this into account to select the most efficient chemotherapeutic regimen. Yes?
Can we see that in the image?
No, it's not easy. No, it's not easy in morphology. You have to do immunohistochemistry. But in all high-grade tumors, you have to make this discrimination. Of course, if you can do molecular analysis, it's preferable, but it's not routine. However, these immunohistochemical stains can be performed on a routine basis in everyday practice. All right. Yes? Something you want to ask? Okay. You see the time? No delay. We start, and it's 3/4. Yes, if you leave me, I can keep you here all day. It will be my pleasure. I don't know yours, but it will be mine. That's another issue. Have 3/4, finish. Because I follow the Japanese system. No European, no American. The Japanese system. Yes, I'm coming. I'm coming.